Welcome to the deep dive. Today we are really aiming high. We're going for a surgical level mastery of the temporomandibular joint, the TMJ. Seems small, right? But it's incredibly complex. Our sources, they get quite technical, calling it a bilateral diarthrodial jinglymoid synovial joint.
That's quite a mouthful, but each term is packed with meaning. Bilateral, obviously, two sides. But the really unique thing, the thing that makes it so tricky, is that the teeth, the occlusion, sits between these two joints.
So they're completely interdependent.
Absolutely. You get a tiny, tiny shift in one joint, maybe the disc slips just a millimeter, and bam, the whole bite, the occlusion is immediately altered. It throws everything off.
Okay, so it's this finely tuned machine. It handles chewing, helps with swallowing, and even lets us talk properly. Our mission today, for you listening, is to go beyond just a summary. We're using top-tier surgical anatomy sources to master the details. From embryology right through to, well, the really complex surgical stuff, the hazards. We want to get you thinking at that elite professional level.
Exactly. It's a deep dive for sure. Right. So to really get this joint, you have to start at the beginning. Embryology. It forms pretty early on, actually, in membrane from two different clumps of neural crest mesenchyme.
And the timing? When does this actually happen?
It's between the 8th and 12th weeks in utero. By week 12, you can already recognize a basic joint structure forming there.
And what I found fascinating in the sources is that the growth doesn't just stop early. It keeps going, sometimes for decades, right? Which obviously has huge clinical implications.
That's a critical point.
Yeah.
There's this specialized growth center, sort of a hub for bone development, just below the condylar head. And yeah, it can stay active well into the third decade of life.
So if it stays active too long...
Then you run into problems like condylar hyperplasia. That usually shows up in the second or third decade, young adults presenting with this progressive facial asymmetry, often just on one side.
And the flip side is not enough growth.
Exactly. If growth is deficient, you see that much earlier, usually in the first decade. Think conditions like hemifacial microsomia. And another really important thing about this growth center, it's incredibly sensitive to trauma.
Meaning surgery itself can cause problems.
Precisely. Even a procedure like a high condylar shave, which might be done to correct overgrowth, carries a real risk. You could inadvertently induce growth arrest if you're not careful, especially in younger patients.
Wow, okay. That really underlines the need for precision. So let's move from how it grows to how it moves. You called it jinglymoid earlier. What does that actually mean for, say, opening your mouth?
Jinglymoid basically means it acts like a hinge, but it's more complex than just that. It's really a two-phase system. You got the condylar head and about the top centimeter of the condylar neck, all housed within the joint capsule. That's the lower part of the joint.
Okay, take us through phase one, the simple hinge part.
Right. Phase one is just rotation. Pure hinge movement. The condylar head rotates against the articular disc, and this happens entirely within the lower joint space.
Lower joint space only for rotation. And how much opening does that give you?
Not much, actually. Clinically, that rotation alone corresponds to about 26 millimeters of opening between the front teeth.
26 millimeters. That's barely enough to get a spoon in. So for a big yawn or taking a huge bite of an apple, you need phase two.
You got it. To get beyond, say, 30, 35 millimeters, you need phase two. Translation. The whole unit, the disc and the condyle together, has to slide forward anteriorly. It glides onto this bony ramp called the articular eminence.
And that sliding, that translation, happens in the upper joint space.
Exactly. That movement happens within the upper joint space. All your protrusion, moving the jaw forward, and your lateral movements, side to side, they all rely on this translation phase.
Okay, this two-space, two-movement system immediately gives us a way to think about problems, like when someone can't open their mouth fully.
It really helps simplify the diagnosis. If someone has limited opening or trismus, the cause is generally either extra-articular, meaning outside the joint itself, usually muscle spasm, like masseter spasm, or it's intra-articular, inside the joint. And if it's intra-articular, the problem is almost always related to that second phase. It's something stopping the translation. Usually it's an issue in the upper joint space or with the disc itself, preventing that smooth slide forward onto the eminence.
Let's talk about that disc then. It seems to be central to so many TMJ problems. Anatomically, it's described as smooth biconcave, made of this multidirectional type fibrocartilage. Sounds pretty robust.
It looks robust, and structurally it is initially. But here's the kicker, the biological flaw that really defines TMJ pathology.
Which is?
The disc becomes avascular. It loses its blood supply very soon after birth.
No blood supply.
None intrinsically. And that means, crucially, it's essentially incapable of repair.
Right.
Once it's damaged significantly, whether through trauma or just chronic wear and tear, it cannot heal itself like vascular tissues can.
Wait a second. So the bit that takes all the grinding, all the chewing force, all the impact over a lifetime, that part is designed so it can't self-repair. That seems like a design flaw.
You could definitely argue that. It makes early damage, or even chronic low-level damage, potentially permanent. It really dictates how we have to approach treatment. If you slice the disc sagittally, you can see its different parts clearly. There's a thicker anterior band, then a thinner intermediate zone, that's the main load-bearing area, and then a thicker posterior band.
And when this avascular structure starts to break down, what do we see?
We see signs of degeneration, often not on the disc itself initially, but on the bone it articulates with, mainly the condylar head. The body tries to compensate, but poorly. You get things like osteophytes, little bone spurs, subchondral cysts just beneath the surface, and areas of abnormal bony sclerosis like hardening. This avascular nature is also why an intercapsular fracture, a fracture inside the joint capsule involving the condylar head, is such a big deal. If that fracture disrupts the blood vessels feeding the bone of the condyle itself,
Then the bone dies.
you risk a vascular necrosis of the condylar head. High risk. It's a serious complication.
Okay, let's zoom out a bit to the structures housing this joint. The glenoid fossa, the socket part in the temporal bone. It's often pictured as this solid cup, but the sources emphasize it's actually quite thin, quite delicate.
That's right. The fossa itself, which forms the thin roof of the TMJ, isn't massively thick bone. It has this sort of S shape, a sigmoid curve. Anteriorly, it's bounded by the articular eminence, that's the ramp the condyle slides onto. Posteriorly, you've got the retroarticular prominence, which is basically continuous with the bone, forming the external auditory canal, the EAC.
That closeness to the ear canal is definitely something to keep in mind during surgery, isn't it? But sticking with the boundaries for a second, how does dislocation fit into this picture?
An anterior dislocation, the common type, happens when the condyle translates too far forward. It slips up and over the peak of the articular eminence and gets stuck there, anterior and superior to it. That's what you see in people with hypermobility, sort of loose joints. And containing all this is the joint capsule itself, made of fibroelastic tissue.
And thickened, part of that capsule forms the lateral ligament, right? Which is a key landmark for surgeons.
Yes, the lateral ligament is essentially just a reinforced thickening of the capsule on the outer side. It attaches down onto the condylar neck, maybe up to a centimeter below the actual joint line. Surgeons often use it as a guide to find the right level to enter the joint. And, there's actually quite a bit of debate in the surgical world about whether you absolutely need to repair that capsule tightly after surgery to prevent the joint from becoming unstable or dislocating again later.
Interesting. Okay, what about the ligaments outside the capsule, the ones acting like check reins?
Yeah, those are the extracapsular ligaments, and yeah, they act like safety straps to limit extreme movements. The main ones are the sphenomandibular ligament.
Which limits?
It primarily limits excessive lateral movement, side-to-side shift to the mandible. Clinically, it's important because if it gets injured, say in trauma, it can sometimes calcify, harden up, and then act like a permanent tether, causing really limited mouth opening.
And the other big one?
That's the stylomandibular ligament. It runs from the styloid process, that pointy bit of bone behind the ear, down to the angle of the mandible. Its main job is to limit extreme mandibular protrusion, like really jutting your jaw forward. It gets tight at the end ring of that movement.
The sources also mention something a bit more obscure, these automandibular ligaments, connections to the ear.
Ah, yes, the discomalleolar and the malleolar mandibular ligaments. These are tiny structures proposed to connect parts of the middle ear, specifically the malleus bone, to the TMJ disc, or the nearby lingula on the mandible. Some anatomists classify them as intrinsic ligaments of the joint, but honestly, their exact function and clinical significance, like whether they contribute to ear symptoms and TMJ disorders, is still pretty debated. They're not as clearly understood or surgically relevant as the sphenomandibular or stylomandibular.
Got it. Let's move inside the joint again to lubrication. You said the disc is avascular, so the synovial fluid must be absolutely critical for keeping it alive, right?
It's lifeline, essentially. The synovial membrane lines the inner surface of the capsule. Importantly, it doesn't cover the main weight-bearing surfaces of the disc or the articular cartilage itself. But the membrane is rich in blood vessels and nerve endings. That's why synovitis, inflammation of this membrane, can be so acutely painful.
And the fluid it produces is the only source of nutrition for the disc. What's special about this fluid?
Yes, it's the sole supplier of nutrients to the avascular disc. It's not just water. It contains specialized molecules like surface-active phospholipids, which provide what's called boundary lubrication, reducing friction when surfaces touch. And it has hyaluronic acid, which gives it viscosity, makes it slippery, and acts like a shock absorber.
But this crucial lubrication system can be disrupted, especially by things like chronic clenching or grinding bruxism.
Absolutely. Repeated, heavy loading from bruxism can literally squeeze the synovial fluid out of the joint spaces. This leads to increased friction and can eventually cause the joint surfaces to stick together, forming adhesions.
And that loss of lubrication can lead to a pretty dramatic clinical picture, can it?
It can. It's called the anchored disc phenomenon. It's basically an acute situation where, due to this loss of lubrication and maybe some early adhesions, the disc gets stuck. The patient experiences a sudden, often painful, loss of joint mobility. They literally can't translate forward.
And understanding that mechanism points directly towards a common treatment, doesn't it? Arthrocentesis.
It's a perfect example of applying anatomy to treatment. Arthrocentesis is essentially washing out the joint. You irrigate the joint spaces, usually the upper space, with saline. This does two things. It physically washes out inflammatory chemicals, cytokines, that contribute to pain and dysfunction. And the fluid pressure can perform a kind of hydrodissection, helping to break up those minor adhesions. By cleaning things out, you allow the synovial membrane cells a chance to recover and start producing healthy lubricating fluid again. It can often restore mobility quite effectively with minimal invasion.
Okay, let's talk about the engines driving all this movement, the muscles of mastication. They're all powered by the trigeminal nerve, specifically V3, the mandibular division. Let's break down who does what. The main closers.
The heavy lifters for closing the jaw, the elevators, are the masseter and the temporalis. Big, powerful muscles.
And for moving the jaw around forwards, sideways.
That's primarily the job of the pterygoid muscles, the medial and lateral pterygoids. They handle protrusion, retraction, and those side-to-side grinding motions.
What about opening the jaw?
Opening is actually done by a group of smaller, generally weaker muscles under the chin, the mylohyoid, the geniohyoid, and the digastric muscle. But, and this is key, they get significant assistance from the lateral pterygoid muscle, especially in initiating the opening movement.
Let's focus on the temporalis for a moment. Its anatomy is really important for surgical access and avoiding nerve damage, isn't it?
Hugely important. The temporalis is that large fan-shaped muscle on the side of your head. It inserts down onto the coronoid process, that triangular projection on the front of the mandibular ramus. Clinically, that insertion point is useful because you can sometimes feel the coronoid process inside the mouth to help pinpoint pain coming specifically from the temporalis muscle, like in myofascial pain syndromes.
But the crucial part for surgeons is higher up, above the cheekbone, the zygomatic arch, where the fascia splits.
Exactly. Covering the muscle is the temporal fascia. Just above the zygomatic arch, this fascia splits into two layers, a superficial layer and a deep layer. Between them is a small fat pad. This split isn't just an anatomical curiosity, it's a critical surgical landmark, because the temporal branch of the facial nerve runs within that superficial layer of the temporal fascia.
So knowing that dictates exactly where a surgeon needs to dissect to protect that nerve.
Absolutely. To stay safe, the dissection plane needs to be deep to that superficial fascial layer. You're essentially dissecting within that fat pad or right down on the deep layer of the fascia covering the muscle itself. That keeps your instruments safely underneath the plane where the nerve is traveling.
Okay, let's move to the pterygoids. The medial pterygoid, it sort of mirrors the masseter on the inside, right? Mostly for closing.
Yes, the medial pterygoid helps elevate the mandible. It has two heads, originating from the lateral pterygoid plate and the maxillary tuberosity. But its key action, besides closing, is its role in lateral movement. When the medial pterygoid on one side contracts,
It pulls the jaw to the opposite side.
exactly. Contraction causes lateral excursion to the contralateral side. It works together with the lateral pterygoid for protrusion as well.
But the lateral pterygoid, the sources really emphasize this one, it seems to be the key muscle for controlling the disc itself.
It is arguably the most functionally significant muscle when it comes to TMJ dysfunction. It also has two heads. The inferior head attaches mainly to the neck of the condyle in a little depression called the pterygoid fovea.
And the superior head, this is the critical one.
This is a critical one for the disc. The superior head originates from the sphenoid bone and attaches directly, quite deliberately, onto the articular disc itself and also a bit onto the capsule.
So if that specific head of the muscle goes to spasm.
Then you have a direct mechanical link to disc problems.
Mhm.
The superior head's job is to help pull the disc forward during opening and protrusion if it becomes hyperactive or goes into sustained spasm.
It can pull the disc too far forward and keep it there.
Precisely. It can cause restriction of opening, but more dramatically, it's considered the primary muscle involved in anterior disc displacement without reduction. That's the clinical scenario where the disc slips forward and stays forward, preventing the condyle from seating properly, what patients often describe as a locked jaw.
Wow, okay. That connection is vital. Now let's trace the wiring. The sensation, pain, position sense, where does that primarily come from?
The main sensory nerve supply to the TMJ is the auriculotemporal branch. This is a branch of the mandibular division, V3, of the trigeminal nerve. It also gets some input from the masseteric nerve and the deep temporal nerves. That rich innervation explains why TMJ problems can be so painful.
And it's not just pain, right? The joint needs to know where it is in space. Proprioception.
Yes, proprioception is crucial. There are specialized nerve endings, mechanoreceptors for sensing pressure and movement, and nociceptors for sensing pain packed into the joint capsule, the lateral ligament, and especially the tissue behind the disc, the retroauricular tissue. This constant feedback stream allows for incredibly fine, unconscious control of jaw posture and movement. It helps protect the joint from damage during chewing, for example.
Given its importance and proximity during surgery, let's just quickly retrace the path of that main nerve, the auriculotemporal.
Sure. It comes off V3, runs posteriorly along the side of the lateral pterygoid muscle initially. Then it hooks medially, passing through a pretty tight spot between the sphenomandibular ligament and the neck of the mandible itself. From there, it swings back out laterally, running behind the TMJ capsule, and then ascends upwards in front of the ear to supply sensation to the skin over the tragus, parts of the outer ear, auricle, and the temple area posteriorly. Knowing that path is key for both local anesthetic blocks and avoiding injury during dissection. All right, now we're moving into the really high-stakes territory, the blood vessels. Missteps here can have catastrophic consequences. The main arterial supply feeding the TMJ region comes from the terminal branches of the external carotid artery, ECA.
And those are?
The superficial temporal artery, STA, and the maxillary artery, MA. The ECA usually splits into these two branches about 2 centimeters or so below or proximal to the condylar head.
So as soon as you make that standard preauricular incision in front of the ear, the STA is right there, isn't it?
It's the first major vessel you're likely to encounter superficially. The STA and the vein running with it lie directly on top of the superficial temporal fascia. They're definitely at risk during that initial dissection, especially if you need to extend the incision upwards, like for a temporal approach. You have to carefully identify, retract, or sometimes ligate these vessels.
Okay, superficial bleeding from the STA is usually manageable, but the deeper you go, the more complex the vascular picture gets, particularly with veins.
Yes. As you dissect deeper, especially if you're doing something like removing the disc, discectomy, or preparing the bone for a joint replacement, you'll run into the pterygoid venous plexus. This isn't a single large vein, but rather a complex network, a sort of mesh of thin-walled veins lying on and around the lateral pterygoid muscle. Bleeding from this plexus can be really troublesome. It's often profuse, difficult to pinpoint, and can quickly obscure your surgical field. Further down, near the lower edge of the pre-auricular incision or the medial side of the ramus, you might also encounter the retromandibular vein.
But the biggest arterial threat, the one that causes the most concern, especially during bone work like a condylectomy, comes from the maxillary artery and its branches.
Absolutely. The maxillary artery, MA, is the major player deep in this region. During a condylectomy, when you're removing the condylar head, one of its branches, the masseteric artery, is particularly vulnerable as it runs across the sigmoid notch, that dip between the condyle and the coronoid process. The main trunk of the MA itself usually lies just superficial to the lateral pterygoid muscle, so it's right there in the base of your dissection field.
And even deeper than the MA, there's another artery to worry about medially.
Yes, deeper still, particularly near the medial aspect of the joint, closer to the skull base, lies the middle meningeal artery, MMA. This is the artery that goes up into the skull to supply the dura mater. While it's deeper, aggressive medial dissection, especially around the disc or lateral pterygoid, can put it at risk. Injury here is very serious.
Okay, this paints a picture of significant vascular risk. The sources mention a specific protocol for the most difficult cases, like severe ankylosis where the bone fusion extends medially. What's the mandate there?
All right. If you have imaging, like a CT scan, showing that the ankylotic bone mass, the fusion, is extending medially and is very close to or even encasing the maxillary artery, the risk of tearing that artery during removal of the bone is extremely high. In those situations, the standard protocol is preoperative selective embolization of the maxillary artery. An interventional radiologist goes in before the surgery and blocks off the MA on that side. This dramatically reduces the arterial pressure and potential blood loss if the vessel is inadvertently injured during the operation. It's a critical safety step.
Makes sense. Now let's talk about the nightmare scenario. You're in surgery, maybe the embolization wasn't done or wasn't fully effective, and you get massive, uncontrolled arterial bleeding, likely from the MA or one of its branches. The textbook response is to ligate the external carotid artery, ECA, down in the neck. But where you ligate it makes a huge difference, doesn't it?
A critical difference. This is pure surgical anatomy knowledge saving the day. If you tie off the ECA lowdown, below the point where the facial and lingual arteries branch off, the linguofacial trunk, you only reduce blood flow to the MA territory by about 40%. There's still significant collateral blood flow coming from other branches.
40% isn't going to cut it if you have torrential bleeding.
Not even close. You need to go higher, more distal on the ECA. If you ligate it above the linguofacial trunk, the flow reduction improves significantly, up to about 73%. But the real key, the detail that the sources emphasize for maximum control, is ligating the ECA even higher, above the origin of the posterior auricular artery. Doing that clamps down the vast majority of the collateral supply. Ligation at that point reduces flow by an incredible 99.2%.
Wow. 99.2% versus 40%. That tiny difference in where you place the ligature is potentially life-saving.
Absolutely. It turns catastrophic hemorrhage into something potentially manageable. Knowing those specific anatomical levels for ligation is non-negotiable for anyone operating in this area.
Okay, shifting gears slightly, but staying in the realm of major hazards. The facial nerve, cranial nerve the 7. It doesn't actually control the TMJ itself, but its proximity causes, well, considerable anxiety for surgeons, right? Because damage means facial paralysis.
It's the dominant concern in planning almost any open TMJ approach. The nerve itself isn't involved in joint function, but its branches run right through the surgical field. You have to know exactly where they are and how to protect them. The two branches most at risk are the temporal branch superiorly and the marginal mandibular branch inferiorly.
Let's start with the temporal branch, the one that lifts the eyebrow. Where exactly is this notoriously variable nerve? We need the specific measurements.
Right, variability is key here. The temporal branch runs within that superficial layer of the temporal fascia we discussed earlier. As it crosses over the zygomatic arch, its location relative to the front of the ear canal, the bony EAC, is crucial. The sources state it crosses the arch anywhere from 8 millimeters to 35 millimeters anterior to the bony EAC. The average position is around 20 millimeters or 2 centimeters in front, but you absolutely have to respect that wide 8 to 35 range. You can't assume it's just at the average spot.
Okay, given that variability, how does a surgeon safely get down to the zygomatic arch, which they need to do for the pre-auricular approach, without hitting that nerve potentially lying anywhere in that zone?
The standard, safe technique relies on dissecting in the correct plane. You perform a superior steel dissection directly on the bone of the zygomatic arch. Remember, the nerve is superficial to this, and the fascia above the bone's covering, the periosteum. By staying right down on the bone, lifting the periosteum with the superficial tissues, you create a protective layer. You're essentially tunneling underneath the plane where the nerve is traveling.
Makes sense. And the sources also mentioned a safe zone for the initial soft tissue dissection.
Yes, as a general guideline for the initial incision and superficial dissection, you can proceed relatively safely in a corridor that starts about 5 millimeters anterior to the bony EAC and extends upwards towards a point roughly 2 centimeters superior to the lateral corner of the eye, the lateral canthus. Staying within that zone during the very initial phases helps minimize risk to the main temporal nerve branches.
Okay, let's drop down to the lower face, the marginal mandibular nerve. This one controls the lower lip.
Correct. It's responsible for depressing the lower lip, crucial for facial expression. This branch typically runs deeper, within the substance of the parotid gland initially. As it emerges, it passes over the masseter muscle, usually heading in a direction from posterior superior down towards anterior inferior. Generally, it stays above the lower border of the mandible. However,
There's anatomical variation again?
always, in some individuals, the nerve or branches of it can dip below the angle of the mandible. particularly where it crosses over the facial artery and vein as they loop up onto the face.
And that's the major risk when using a submandibular approach, say, for fixing a ramus fracture.
Exactly. If you're making an incision below the mandible, the key safety maneuver is to dissect carefully in the subplatysmal plane, staying superficial to the investing layer of deep cervical fascia. This fascia bundles the nerve. By staying above it, you can identify the nerve branches and gently retract them upwards, out of harm's way. Going too deep puts them at direct risk.
Beyond the facial nerve, are there other nerves we need to worry about, maybe deeper in?
Yes, particularly during more extensive procedures like dealing with significant ankylosis or placing large prostheses. The sensory nerves to the lower jaw and tongue, the inferior alveolar nerve running inside the mandible, and the lingual nerve running medial to it lie deep to the lateral pterygoid muscle. Aggressive medial dissection or forceful retraction to mobilize a fused joint can potentially stretch these nerves, leading to temporary or sometimes permanent numbness or altered sensation in the lip, chin, or tongue.
And specifically with joint replacement surgery.
When placing the ramus component of a total joint prosthesis, especially the most anterior screws used to fix it to the mandible, you have to be extremely careful. Those screws are placed very close to the path of the inferior alveolar nerve as it enters the mandibular canal near the lingula. Misjudging the angle or depth could directly injure the nerve.
Okay, let's shift from nerves to bone hazards. We mentioned the thin roof of the glenoid fossa. What other bone-related pitfalls are there?
Well, first, a surprisingly common error for less experienced surgeons is actually mistaking the external auditory canal, EAC, for the joint space itself.
Seriously, how do you avoid that?
The absolute key precaution before making any bone cuts in that area is to move the patient's jaw, manipulate the mandible. If the structure you're looking at moves with the jaw, it's the condyle joint. If it stays perfectly still, it's likely the fixed bony EAC. Seems simple, but it avoids a disastrous wrong turn.
Good tip. What about the bone structure itself? Pneumatization. Air cells where they shouldn't be.
Right. The glenoid fossa roof can be thin, as we said, but both the fossa and the articular eminence can also be pneumatized. This means they contain air cells connected to the mastoid air cell system. You really need good preoperative imaging, like a cone beam CT, CBCT, to identify this. Why does it matter? Well, if you're doing a procedure like an eminoplasty where you're reducing the height of the articular eminence, sometimes done for chronic dislocation.
You could break into those air cells.
Exactly. There's about a 2–5% chance of perforating into mastoid air cells within the eminence. This creates a direct pathway for infection to spread from the joint into the mastoid system, or potentially even expose intracranial contents if the pneumatization extends very high.
And that risk of intracranial penetration going through the roof of the fossa into the middle cranial fossa is perhaps even higher with closed procedures.
It is, arguably. While rare, inadvertently puncturing superiorly through that thin glenoid fossa roof is a known devastating complication, more commonly associated with arthroscopy. When you're manipulating instruments somewhat blindly within the upper joint space, there's a risk, if not extremely careful, of pushing too hard superiorly and breaking through into the cranial cavity. It highlights just how thin that barrier can be. Okay, let's talk about the actual surgeries. Broadly, they fall into two camps. You've got the closed procedures, which are less invasive. These mainly involve washing out the joint or looking inside with a scope, so arthrocentesis and arthroscopy.
And then the more involved open procedures.
Right. The open joint procedures require actually cutting into the joint capsule. This includes things like discectomy, removing the disc, discplication, repairing or repositioning the disc, eminoplasty, reshaping the eminence, total joint replacement, and ORIFF open reduction and internal fixation for fractured condyles.
We definitely need to nail down the standard open approaches. Let's start with the most common one for accessing the joint itself. The pre-auricular approach, often the Bramley-Alkayat modification.
This is the workhorse approach for disc surgery, eminence work, things like that. The incision is typically made right in front of the ear, often hidden in a natural skin crease. You deepen the incision carefully, aiming for what's called the pre-cartilaginous avascular plane, a relatively safe layer just in front of the ear cartilage. You continue dissecting downwards and slightly forwards until you clearly identify that whitish fibrous layer, the superficial layer of the deep temporal fascia.
And following that fascia down protects the temporal nerve branch, as we discussed.
Exactly. You follow that fascial plane downwards until you can feel the solid bone of the zygomatic arch base. Once you're there, to get down to the joint capsule below the arch, you make a specific releasing incision. It's usually a 45-degree cut made superiorly, starting from the arch base and angling up and forwards into that safe zone we talked about. This allows you to reflect the tissues downwards.
And then you're looking at the joint capsule. How do you get inside?
You use a blunt instrument, like a periosteel elevator, to carefully expose the lateral aspect of the capsule. Then, to open the joint, surgeons typically make 2 connected incisions in the capsule, often a vertical cut along the back edge of the condylar neck connected to a horizontal cut running forward. This creates a small flap you can lift up to see into the upper and lower joint spaces. And importantly, at the end of the procedure, you must get good closure. This involves suturing the lateral capsule securely and often closing the temporalis fascia layer as well to restore stability and try to prevent issues like later subluxation.
Okay, that's the pre-auricular. What about the other main approach, the retromandibular? When is that used?
The retromandibular approach is used when you need access lower down, primarily to the mandibular ramus and condylar neck region. It's the standard approach for performing a condylectomy, removing the condyle, or for placing the ramus component of a total joint prosthesis.
Where's the incision for this one?
It's made below the earlobe, typically about 1 centimeter beneath the lobe, running downwards and slightly forwards, posterior to the back edge of the ascending ramus of the mandible.
This incision goes right through the parotid gland territory, putting the facial nerve branches at risk again.
Absolutely. This approach requires extremely careful, meticulous dissection. You have to bluntly dissect through the parotid gland tissue in its capsule, which can sometimes be quite thin and flimsy, specifically looking for branches of the facial nerve, identifying them, and gently retracting them out of the way, usually upwards and forwards. Once the nerve is safe to get down to the bone of the ramus, you need to divide the pterygomasseteric sling. That's the confluence of the masseter muscle laterally and the medial pterygoid muscle medially, attaching along the posterior and inferior border of the mandible. You cauterize and divide this sling to allow you to peel the muscles off the bones superiostele, exposing the ramus up to the sigmoid notch.
What are the main bleeding risks specific to this approach, and what's crucial for closure?
Bleeding-wise, the retromandibular vein is often encountered in the lower part of the dissection and needs careful handling. If you run into major arterial bleeding that needs ECA ligation, the ECA itself can sometimes be found deeper in the wound, often deep to the posterior belly of the digastric muscle. For closure, the absolute key is getting a watertight closure of the parotid gland capsule. If you leave gaps, saliva can leak out from the gland into the wound space, forming a fluid collection called a sialosal, which is a common and annoying complication of this approach if closure isn't meticulous.
Right, let's put all this anatomy and surgical knowledge together by looking at these 2 complex clinical cases from the sources. Case 1. A 54-year-old woman diagnosed with synovial chondromatosis, but with a twist it had extended intracranially. She presented with pain, swelling, some facial numbness, and limited jaw movement. She could open, 43 millimeters, but her lateral movement to the right was severely restricted, only 3 millimeters.
Okay, that clinical sign, the severely limited movement to the contralateral side, the side opposite the affected joint, that's a huge clue. It immediately points towards pathology in the upper joint space on the left side, something physically blocking that crucial anterior translation needed for moving the jaw to the right. And the imaging confirmed something pretty dramatic. The disease process had actually perforated through the roof of the glenoid fossa, through the skull base, and there was this encapsulated mass invading the left middle cranial fossa. Classic appearance, unfortunately, for aggressive synovial chondromatosis extending intracranially.
Wow. So a TMJ problem requiring brain surgery, essentially. The plan involved that Bramley-Alcott pre-auricular approach, but with a temporal extension, peeling back the temporalis muscle. Why specifically retract the temporalis in this case?
There were 2 main reasons for mobilizing the temporalis muscle upwards and forwards. First, it provided the necessary surgical access for the neurosurgeons to perform a craniotomy in temporal bone, allowing them to get into the middle cranial fossa to remove the intracranial portion of the lesion and assess the dura. Second, by preserving the temporalis muscle and its fascia, it remained available as a potential reconstructive flap, like an interposition graft, just in case there was a dural tear during the resection, or if some cranial base reconstruction was needed after removing the diseased bone.
Smart planning. What did they actually find once they got in there, both in the joint and intracranially?
In the joint, they found exactly what you'd expect. The upper joint space was markedly enlarged and filled with those characteristic loose bodies, glistening, cartilaginous nodules. Intracranially, through the craniotomy, they confirmed the lesion extended upwards. It looked cystic and was clearly pushing on the dura mater, but luckily it hadn't grossly invaded or penetrated through the dura itself.
Still, removing it left a significant defect in the skull base. How was that reconstructed?
That required a multi-layered approach. First, they used a split calvarial bone graft, taking bone from the patient's own skull nearby to reconstruct the floor of the middle cranial fossa, basically rebuilding the roof of the glenoid fossa. Then, to cover the larger defect created by the craniotomy itself, they placed a titanium cranioplasty mesh or plate. Obviously, the pre-op multidisciplinary team discussion would have been extensive, covering the major risks. Permanent facial nerve weakness from the extensive dissection, a potential dural tear leading to a CSF leak, or a serious intracranial bleed, high-stakes surgery.
Absolutely. Okay, case 2 focuses on the opposite problem. Not overgrowth, but fusion TMJ ankylosis. This was a 37-year-old man with progressively worsening limited opening down to only 11 millimeters and critically no lateral movement to the right side at all.
Again, the clinical signs are key. Progressive limitation plus that complete lack of lateral deviation strongly suggests a developing joint ankylosis on the affected side, in this case, the right side. The bone is literally fusing across the joint's base, locking it up. 11-millimeter opening is severely restricted.
Before they even started cutting bone, the sources stress a crucial pre-op consideration if that bony fusion had extended medially towards the skull base. What was that?
If the pre-op CT scan had shown that ankylotic mass extending medially, getting close to the pterygoid plates or the base of the skull where the maxillary artery runs, then performing preoperative angiography and potentially embolization of the maxillary artery would have been considered mandatory. It comes back to that risk of catastrophic hemorrhage during resection of the fused bone block. You have to mitigate that risk beforehand if possible.
Makes sense. Now, during the surgery, let's say they resect the main bony block of the ankylosis, but the patient still can't open adequately, maybe only 20 millimeters. What are the next steps according to established protocols, like the Caban protocol?
The goal is usually to achieve at least 30-35 millimeters of passive mouth opening intraoperatively to ensure good long-term function. If resecting the ankylotic mass alone doesn't achieve that, the next step is typically an ipsilateral coronoidectomy, removing the coronoid process on the same side. This releases the pull of the temporalis muscle and any associated scarring. If even that isn't enough, the Caban protocol suggests proceeding to a contralateral coronoidectomy, removing the coronoid process on the opposite side as well to achieve maximum mandibular release.
Once the joint is mobilized, they need to reconstruct it to prevent it from fusing again. What are the options ranked by the risk of the ankylosis coming back?
There's a clear hierarchy based on recurrence risk. The simplest option is gap arthroplasty, just creating a space and leaving it. This has the highest risk of the bone fusing again. Better is interposition arthroplasty, where you place some kind of tissue barrier like temporalis fascia, muscle, or even a buccal fat pad graft into the gap. Better still, especially in growing patients, might be a costochondral graft, rib graft. But for complex adult ankylosis, the option with the definitively lowest recurrence risk is total alloplastic joint replacement, using a custom-fitted artificial joint like the TMJ concepts prosthesis mentioned in the source.
And the surgical plan for implanting that total joint replacement typically requires using both of the approaches we discussed earlier.
Yes, it's often a combined approach. The final resection of the ankylosis and the condylectomy part might be completed from below, using the retromandibular approach for good access to the ramus. Then, the artificial fossa component is placed from above via the pre-auricular approach, while the ramus prosthetic component is secured to the mandible from below via the retromandibular incision. A useful adjunct often mentioned is placing a free fat graft, typically harvested from the abdomen, around the artificial joint articulation after it's placed. This is thought to help reduce the risk of heterotopic bone formation, abnormal bone growth around the prosthesis, which can contribute to re-stiffening.
And the preoperative risk discussion for this kind of major reconstruction has to cover pretty much every hazard we've detailed today, doesn't it?
Absolutely. You're talking about potential damage to the facial nerve, particularly the frontal branch during the pre-auricular part. You're discussing the significant risk of severe bleeding, potentially needing that ECA ligation. You have to mention the risk of a silocele from the retromandibular approach. And even with the best prosthesis, you still have to discuss the small but real risk of recurrence of the ankylosis or other long-term complications. It's a comprehensive consent process. #OuchRater.
So we've gone incredibly deep today. I feel like we've really mapped out the critical terrain needed for that mastery level. We've covered the unique two-stage movement, the almost tragic flaw of the avascular disc, the pivotal role of that superior head of the lateral pterygoid in dysfunction, and navigated the dangerous pathways of the facial nerve and the maxillary artery.
It's fascinating, isn't it? How the intricate interplay between the joint's mechanics that hinge and slide and all the surrounding soft tissues, the ligaments, the disc attachments, the muscles, how all that means even seemingly small pathologies, like just a loss of lubrication or a bit of muscle spasm, can snowball into major functional limitations, like an anchored disc or even complete bony fusion in ankylosis.
The precision required in such a variable and tightly packed anatomical space is just staggering.
It really is. And maybe the final thought to leave you with, building on that first case, is just the sheer anatomical audacity of this joint's location.
Hmm.
You have this mechanical structure designed for chewing and grinding under immense force, sitting literally millimeters away from the delicate structures of the middle ear, the middle cranial fossa, and the brainstem itself. The fact that treating a jaw joint problem sometimes necessitates a full craniofacial approach involving neurosurgeons to repair the skull base speaks volumes about this inherent structural vulnerability.
A powerful reminder of evolutionary trade-offs, perhaps.
Perhaps. So the provocative question to ponder might be, how much of the complexity and surgical risk associated with structures around the head and neck is ultimately dictated by the non-negotiable biological imperative to protect the brain at all costs? It certainly shapes everything we do in this region.